So traditionally, we have looked in the myeloma realm to see what's FDA approved, and then we try to look at it in amyloidosis patients. Now, if you look at the history of that, there are certainly agents that are used in myeloma, which then are studied in amyloidosis patients, and it proves to be too toxic, or the side effect profile is unexpectedly toxic. A perfect example of that is lenalidomide. For example, it's a very common agent used in frontline therapy for myeloma, though in amyloidosis patients can be cardiotoxic. And we try to shy away from full doses of lenalidomide. Carfilzomib is another one. So that being said, any agent that is approved in myeloma really need to be studied in amyloidosis because the disease is very different. So the side effect profile could be very different. But that being said, there's a lot of excitement about the use of these agents. During the panel yesterday, one of the questions was, for CAR T patients in amyloidosis, is that really appropriate? And I would argue that I think it may be appropriate. We need to do that study. And it may be a question of patient selection. So long time ago, with autologous stem cell transplant for AL amyloidosis, people found that the transplant-related mortality with an auto is actually higher than a myeloma patient. And over time, we have learned that the key lies in patient selection and making sure the right patients move on to receiving that type of therapy. I suspect that will probably be the case for CAR T therapies in AL amyloidosis patients, but again, the study needs to be done. Likewise, with T-cell engagers, it's the same thing. T-cell engagers as well as CAR Ts, they lead to cytokine release syndrome, and sometimes it could be moderate and severe. So who are the right patients that we should choose to receive that type of therapy remain questions that need to be answered.